This session is going to begin in about 1 minute. I'm just going to give folks a second to jump on. Joining me today is Jessica Henkel, and she is helping me behind the scenes today. And we'll be jumping on to chat, putting links in the chat for us, and then helping just with any questions that you might have about the topics. Hi, Jess. How are you today? So I'm Jana, and I'm coming to you from the Grand Rapids, Michigan area. It is about 84 and sunny. It does not feel like fall here. That little stint that we had this weekend was kind of a nice touch to getting us ready for the next season. And with Labor Day, we know that a lot of kids went back to school. And I work along with Jessica and Patty and Amy, who will be joining us later on these presentations, on the Targeted Response QII team. And I just want to give you a quick plug and some information about that. We are seeing an increase in occurrence of COVID-19. We're seeing increased outbreaks across the 3 states, just like across the nation. And we're starting to see some increased hospitalizations with those COVID outbreaks. So if you are new to your role as an infection preventionist and did not work during the pandemic in long-term care, and you would like some resources or support, please feel free to reach out to Jess or I today, and we'll make sure that we put you in touch with your QA, just so that you can make sure that your program is up and ready in the event that you do go into outbreak. We know as that children go back to school, they tend to bring things back and forth and like to share those germs. So we tend to see those respiratory increases in the fall. So I'm going to go ahead and get started. Is everybody able to see my slides? You should be. Looking forward. So this is a 6-week series that we're going to talk with you and cover some topics related to what it means to be an infection preventionist. And for the framework of the education, we're using the FTAGs, and those are the federal guidance and regulations around all things that may touch an infection preventionist or somebody working in that role, a director of nursing, and even for administrators. We're going to talk about the FTAGs of infection control, kind of give you some overview of what they say from a regulatory standpoint, what they kind of mean and how they impact your role, and then provide you with some resources for your program. So we're going to go ahead and jump right in. So the objectives today, and I'm not going to read these to you. This is just really to help you understand the regulations, explain the role and expectations of an infection preventionist. And then today we're going to talk about the common deficiencies or gaps that sometimes lead to citations of F880, and we'll give you some reports from the field, things that we're seeing on 2567s. Those are those reports that you get when the state surveyors come in for a complaint infection controller annual survey. And we're going to give you a clear definition of a policy versus a process or a procedure, and we hope to help identify the goals of this group. So first and foremost, for this group, it is a 6-week series. You can jump in and out. We are recording these. The recordings will be available at a later date after they've been reviewed. But one of the major goals of any affinity group or a work group is that it's a peer-to-peer interaction and that it's not simply didactic. And that's really sometimes hard to do virtually because we're all co-located. I'm in Michigan, Jessica's in Iowa, you might be in Minnesota, Wisconsin. We've had some folks from South and North Dakota jump on before, but virtually we can have a conversation and we can talk about some of the things that are similar across the setting of a nursing home environment. You all face very similar experiences when it comes to infection control practices, getting staff to have compliance with things like hand hygiene and wearing PPE appropriately. And that's kind of a universal theme, right? So we're going to talk a little bit about that. So the goal of this is peer-to-peer learning. It's an opportunity for you to tell us things and for us to teach you things. And then really for this to be a safe place for you all to join and share concerns or issues or thoughts that you might have. If you're not comfortable sharing, it's okay. We don't call on anybody. This isn't one of those places where I will call you out by name, but I would just encourage you to communicate and be interactive with us today. So this is just a little definition of what a work group is. I kind of talked about that. It's about collaborative learning, sharing of best practices, talking about experiences, areas of support. It should be confidential, supportive, and collaborative. So who are we? If you're not familiar with who Superior Health Quality Alliance is, We are contracted with CMS for quality improvement and quality innovation. We work with providers who provide care and services to those in the CMS programs. Primarily, our team works with skilled nursing facilities, but Superior Health overall works with skilled nursing facilities, hospitals, and outpatient offices in Michigan, Minnesota, and Wisconsin. And yes, Jessica will drop the slides into the chat momentarily. I see that in the chat. The Targeted Response QII initiative, we are a group within Superior Health Quality Alliance. We are all infection preventionists. Most of us have long-term care experience, and we work with facilities on infection control, outbreak management, and support for COVID-19. We were stood up during the beginning of the pandemic. So here's the presenters for the series. I am Jana Broughton. I'm a nursing home administrator of 32 years, worked in long-term care all through the pandemic. Jessica Henkel, who is joining me today, is an RN and a nursing home administrator, has worked both as a DON and administrator. Amy Kaiser Magner is an RN, and she worked in long-term care, and she was an educator for long-term care programs. And then Patty Leonard was a former director of nursing and long-term care. And I think we jokingly looked at our years of service, and between the four of us, we probably have worked in long-term care well over 85 years. So we're seasoned. All right, so let's jump right in. So let's talk about some definitions and the difference between policies and procedures. I think this is something that, sometimes when we first start out, we get a little confused about what is a policy and what is a procedure or process. A policy is a course of action. It is that written course of action that you adopt formally, and it is a definitive course or method of action selected from among alternatives. Very high level definition of that. But it's a high-level overview, overall plan, embracing the general goals and accepted procedures, especially of a governmental body. So your policy is that high level. It's kind of what you're stating, what you're going to do. The procedure is the how you're going to do it. It's the establishment or official way of how you're going to do something. It's a document that gives you instructions. So the policy, that's the difference between policy and procedure. The policy talks about the what and the why. The procedure tells you the how and the when. That's kind of how I define it. It's the busy work. The procedure is the action work. So a protocol is a traditional or established way of doing things. It doesn't necessarily mean it's always the right way if it's a traditional way of doing things, but it's a protocol. It's something that we have, maybe we do by rote. It's something that we do, every day, day in and day out. We don't even think about it because it's just become part of who we are and how we do our work. A guideline is a recommendation for best practices. And during the pandemic, we saw guidelines being pushed out, sometimes hourly, from the CDC, from our health departments, as new information came in on COVID and what the virus was, what it wasn't, what we were learning about it. So a guideline is a recommendation for best practices. Here are all the F tags related to infection prevention. I'm just going to let you sit there and think about all of these F tags. This F tag list is not all encompassing. There are others that fall or have aspects of infection prevention. The F tags, the regulatory F tags, often intertwine and overlap, and you will find in the surveyor guidance under Appendix PP. If you've never looked at your F tags and you're new, that's okay. Here is the source. And so this is a live link. When Jessica sends you the PowerPoint, I see that she dropped it in the chat. That link will work for you and it will take you out to Appendix PP where you can find all the F tags. I will give you a word of caution that they are sequential by number. So you're going to have to scroll through to find the specific F tags. They're not by topic area. But generally, as a rule of thumb, the F tags tend to follow groupings. So the 800 F tags, like starting at 880 and going forward, tend to be your infection control. You will see them lumped together. It's odd to have F tags out of sequence that don't kind of correlate with the others around it. Kind of like chapters in a book. So these are all of the F tags. And today we're going to talk about the big one. This is the behemoth. F880 is a very big chunk of regulatory language. It has a ton of information in it, and a lot of it might be overlooked by some facilities. So Jessica, this is poll number 1. So all the following are examples of an infection control policy that are required for a long-term care facility's infection prevention program, except. And this is just to kind of get a feel for where y'all are at. Which ones of these do you think from a policy procedure, which ones of these do you think are not required to have an infection control policy? And Jessica, I see that we can end the poll. Abuse prevention, that is correct. That is correct. That was just kind of a little example for you of how the polling questions work to get you thinking about it. So under F880, this is basically a kind of a synopsis, a really quick screenshot of what it talks about. So it's establishing and ongoing the maintenance of an infection control program. And its purpose is to provide a safe and sanitary environment for your residents, staff, and the families and visitors that come in to help prevent the development and transmission of communicable diseases and infections. We're wanting to prevent those illnesses. And it's a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all persons in a facility. It is written standards. It requires written standards, policies, and procedures for your program. It talks about a surveillance system being in place and established. And then it talks about different standard and transmission-based precautions and identifying when and whom possible incidents of communicable diseases or infections should be reported. So just kind of in a nutshell, this is like a high overview of what F880 covers. So when we talk about the goals of an infection prevention program, and this is from both APIC and Healthcare Epidemiology of America, the real goals of an infection prevention program are these. We want to decrease morbidity, mortality due to infections. We want to prevent and control outbreaks. We want to stop that chain of infection outbreak. We want to prevent staff from becoming infected. We want to keep our staff healthy so they can help us take care of residents and provide services. And we want to limit cost of care due to infections that are preventable and communicable diseases that we can control. And we want to maintain residents' functional status and maintain optimal social environment for the residents. And that kind of gets to the isolation. When you put residents in isolation, that's not an optimal social environment, as those of us learned during the pandemic. So for a facility infection prevention risk assessment, part of F880, there is language around F880 that nursing facilities will conduct, document, and annually review a facility-wide assessment, which includes both the resident population and the resources the facility needs to care for their residents. So when we talk about, there's been a lot of conversation around facility assessment. Some changes came out earlier this year where they talked about the staffing requirements, and the facility assessment was talked about at length and some of the changes around the facility assessment. And when you dig into what they're asking us to do from a facility assessment, there's multiple ways to look at the facility assessment or the facility infection prevention risk assessment along with the facility assessment. So the assessment that you do as a facility, you do it to look at overall, what are we offering? How are we offering it? What types of residents are we providing the care that we are offering? And can we provide that care? And if we cannot, what are we doing to make it so that we can provide that level of care? And what education and training are we providing to our staff? What resources are we providing or bringing into the building to make sure that the residents that we've identified in our facility, that we have everything we need to care for those residents? That's what the facility assessment in a high level is really talking about. Who your population is, what level of care they need, what resources you're going to need, what education and training and expertise your staff are going to need, and then where do you get them? And how are you identifying that out in your community? From a risk assessment, the facility infection prevention risk assessment, this assessment identifies resources needed to care for your residents, not only during day-to-day operations, but also during those emergency situations. So this gets to your emergency plan. And the assessment identifies areas for policy development, staff education, and training. And it should be completed by your interdisciplinary team. And it needs to be reviewed at any time that there's a change in your resident population or with any outbreak or with any new illness coming into your community. So the last bullet here, where we talk about needing to review types of infection in your community, when you look at your infection prevention risk assessment, let's bring it down to how we would apply it in your environment. Measles. Last winter, there were areas of the country that had larger measles outbreaks. Illinois comes to mind. If you saw the news, Chicago area had several people test positive or screen positive for measles, and they were being treated for measles. That would be a new type of infection that could potentially, you never considered a risk for your environment, but now all of a sudden it's a risk. At that point in time, you would probably update your facility infection prevention risk assessment and want to look at the culpability of your nursing facility and your infection control program to begin education and training around measles. Are your staff vaccinated for measles? Do they need to have a titer ran for their childhood vaccines? Are your residents of an age group that probably didn't have exposure as a child or young adult based on measles? And putting that conversation into your facility assessment and possibly looking at your level of risk, where before it might have been a low level of risk, and moving it to a moderate or high level, depending on your community spread. So the risk assessment is ever flowing. It ebbs and flows based on what's going on in your community and the type of population that you're caring for. And the infection control or infection prevention risk assessment looks at all aspects of things from like TB. You might be in an area where it has a higher level of tuberculosis risk, measles, all of those things that are community acquired that could put your residents and your staff at risk need to be identified on your infection prevention risk assessment. So if you need examples of that, or you'd like us to look at that, if you've never heard about this before and you're new to your role as an infection preventionist, I encourage you to go speak to your administrator, your director of nursing, and ask to look at your facility assessment and your risk assessment. I'm going to guess that you're probably looking at your facility assessments right now because that regulation just went into play. I think, Jessica, was it early August, mid-August that came out? I'm trying to remember. Yeah, mid-August. So I'm guessing that was an interdisciplinary discussion and you've heard about that. But I would encourage you to look at your infection prevention risk assessment, read it, review it, and think to yourself, does this make sense for the type of residents we're currently providing care for in comparison to our environment around us, the community, locally, county, and then state. All right, infection prevention policies and procedures. In F880, they talk about having policies and procedures that are based on established practices, evidence-based practices, guidance from experts. So what is an evidence-based practice? It's not something that we just do because we think it works. We know that if we do XYZ, from my past experience, this is what happened. That's not evidence-based, that's experience-based, right? Evidence-based is guidance from research and experts such as the CDC, APIC, and other organizations that do research around infections. Your state epidemiologist, for example, might have evidence-based practices that they pull from when they're writing their state level rules and requirements around infection control. So your policies and procedures need to consider evidence-based practices and guidance from the experts. And a lot of facilities will pull in CDC or APIC references into their policies as a point of reference to state where they, where they found the information to base that practice on. They need to be written so staff understand the policy and procedure and know what to do and when to do it. And your policies and procedures need to be approved by the Infection Prevention Committee, Quality Assurance, and need to be reviewed and signed at your QAPI meeting. So they need to be reviewed and signed by your medical director, your administrator, possibly your DON, your infection preventionist. You all need to review them, put it into your notes in QAPI, and then date that policy and procedure was reviewed. It is required that they are reviewed at a minimum annually or with any changes. I don't know about you, but if you worked during the pandemic, our COVID policies never seemed to get the ink dry on them. They were always changing because the established practices, evidence-based practices were frequently changing and we were learning on the go. If you are using a corporately driven policy and procedure, which we know a lot of facilities have corporately structured policies and procedures, you're still responsible to know what they contain. And they should still give direction to staff and be written in a way that staff understand, know what to do and when to do it. Your policies and procedures should be readily accessible to staff. Do you know if your policy and procedures are electronic? Are they on, on your laptops that your nurses use for MedPass? Can they go in and find a policy and procedure? Is it in a written book behind the nursing station and in everybody's office? And they should be updated when guidance changes. When was the last time you pulled your policies and procedures? Now, infection control, again, your policies and procedures are probably multiple changes, multiple red lines, multiple updates over the past 4 years. COVID brought that to a highlight, and then there's been multiple things that we've done. Enhanced barrier precautions, for example, that probably drove some changes with your policies and procedures. And your policies and procedures should reflect that you have updated it in review of guidance changes. And then again, they require annual review, and that review should be documented in your QAPI minutes to prove that you did do that review. So here's some basic examples of policies and procedures that are needed for your infection control program. They need to be based on your risk assessment. You should have policies and procedures about your surveillance, i.e. auditing program. What are you going to look at? When are you going to look at it? How are you going to look at it? You should have policies and procedures on standard precautions and then topics around standard precautions, such as hand hygiene, injection safety, cough etiquette, transmission-based precautions, isolation policies, use of PPE and enhanced barrier precautions, for example, and then outbreak management. What do your policies state about outbreaks, and not just COVID outbreaks, influenza, norovirus? What does your policy state about what you're going to do when you have an outbreak? Policies and procedures if you offer any specialty services, for example, ventilator care or in-house dialysis. Then again, the other topics, and this kind of talks back to that F-tag overlap. So wound care, skin care, incontinence care should all have elements of infection control, such as hand hygiene and technique, that would be relevant to infection control practices. Medication administration, think about eye drops. Those are things that are very specific on how you administer from an infection control standpoint. Diabetic medications, injections, and then your vaccine policies, vaccination policies and procedures. Again, going back to changing guidance, every time there is a new vaccine that is recommended by those experts at the CDC or APIC, you should be pulling out your policies and procedures for example, vaccines, COVID vaccines. Did they change the recommendations? Is the vaccine policy still applicable? I would encourage you to think about correlating your vaccine policy review to the time when vaccines are more prevalent, i.e. right now, right? It's the fall. So pull your vaccine policies out like August, September, do that review, make sure the language is still applicable. Do you have the VIS? Are you using the VIS, or are we using a package insert for the vaccines because we don't have a VIS, which when we get to the COVID vaccines, we'll talk about that because we do not have a VIS form yet for the new vaccine. So what is your policy and procedure state for that? And looking at it now before you give those vaccines indicates that you are aware that this is what you're going into a changed potentially vaccine season. So always a good practice to kind of think about where it applies on the calendar and in your program. All right. Also in F880, it talks about reporting illnesses and maintaining a state list of reportable diseases. On this slide are the live links that will take you to the updated list for all 3 states that we participate in. And every year these lists get updated with the new reportable diseases and how you report them to your specific state Department of Health. And if you have any additional questions on that, we can get you in contact with the Minnesota, Wisconsin, or Michigan epidemiology or state health department representatives that we've worked with to talk about disease reporting and how they want to report, how they would like it reported. I will say there are some nuances to this because we've worked across all 3 states and we know some counties here in Michigan, for example, prefer to have it electronically reported. Others want a phone call, some want an email, some want 2 or 3. So it's always good to know who your point of contact for your health department is and how they prefer that messaging. And then make sure that you document. I always send them an email to follow up on any phone conversation to prove that we talked about something. Just kind of a best practice. F880 also talks about staff education and competency, and you're going to see staff education and competency intertwined in pretty much any F tag that is resident care driven in the SOM. Staff education and competency is often an overlooked aspect of any F tag that we see facilities getting cited for. The regulations are very specific around requiring facilities to provide staff not only with education, which a lot of facilities utilize online virtual modules such as Relias or Healthcare Academy, or it can be staff-led classroom presentations. It can be independent study. As long as you have a means and a way to document that you provided the staff with that education and you have some mechanism of testing their competency afterwards or testing their comprehension, I should say comprehension, not competency, their comprehension of the material that they've reviewed. Education and competency on infection control is required when we hire staff and onboard them. With any changes in policy, procedures, or products, and then with best practices. And it's a best practice to do it when you have an outbreak, any variance in infection rates. You see UTIs, for example, are increased from this month over last month. And you're doing a root cause analysis and you're trying to pinpoint why are we seeing an increased UTI rate. And you boil it down to like maybe 3 aspects. Staff education is part of it, right? So we're going to do education with that. When performance does not meet standards, when you're observing care or you're, for example, you're walking down the hall and you see staff coming in and out of rooms and you're not seeing them foam in and foam out. That's a visual observation that indicates that you probably have, and if it's more than one staff, it's not an isolated incident, it's a little bit of a pattern. You probably need to go back and do some staff education around hand hygiene. Competency validation is also required. And what is competency validation? We're going to talk a lot about this, and I want to make sure that we understand comprehension versus competency. Comprehension is, I give you a written test of ABC questions, you give it back to me, and you score 95%. Maybe somebody's good at taking a test. Competency is the application of the requirement. It is the actual physical observation of staff going in and out of rooms, foaming in, foaming out. It's staff being able to verbalize and demonstrate to you how to do the foam in, foam out, how long the product needs to touch, how, what type of technique they use when they wash their hands. Competency validation also includes that post-test and observation. So it's 2 types of competency. You wanted to have staff demonstrate to you either upon directed observation or indirect, like secret shopper observations, where you're just kind of in the background watching. You want to see that they're competent in what they're doing. And that is intertwined in a lot of the F tags, that word competency. So I think, we'll talk more about that as we go on. Is there any questions in the chat that anybody has? I've talked about a lot on F880. It's a high-level overview. You're going to see it intertwined in a lot of the different things that we talk about with the F tags. Jessica, anybody got any questions so far?
None in the chat.
Okay, awesome. So we're going to jump now into F882, the infection preventionist. And we're going to talk about this just a little bit. But here's the first, I want to start with a polling question. Which of the following are required responsibilities for the role of a long-term care infection preventionist? They need to work at least part-time directly in the facility, have specialized training in infection prevention and control, have primary professional training in nursing or medical terminology, microbiology, epidemiology, or another related field, and then D, be qualified by education, training, or certification. I am seeing these numbers, and we have a very, very smart group today. Or y'all have read, you went and read ahead, and you saw the F tag, or you know about the F tag. So we can go ahead and end that. That was good. Thank you. So yes, it is all of the above. Little known fact, you do not necessarily have to be a nurse to be an infection preventionist. You heard me say I'm an administrator. I am not a nurse. I was trained to be a social worker and practiced social work for about 10 years in long-term care before I became a nursing home administrator. But I did take the infection preventionist course, and obviously I work with you all as an infection preventionist. I come at it with a little different aspect. But you can have, so if you have primary professional training in medical terminology, microbiology, epidemiology, or other related science fields, you can become qualified by education, training, experience, or certification to become, the IP in a long-term care facility. So what does the F882 state? It says that you must designate one or more individuals as the infection preventionist who are responsible for the facility's infection prevention and control program. And you must work at least part-time, and you have to complete specialized training in infection prevention and control. And again, when we talk about specialized training, we're not talking about taking a Relias course. We're talking about necessarily a training course that was provided by a recognized source, such as the CDC, APIC, or others. And the intent of this regulation is to ensure that the facility designates a qualified individual on site who's responsible for implementing programs and activities to prevent and control infections. That we are seeing an uptick in F882 citations for facilities for not having a person in place with the required training. And I'm going to give you some examples. For example, facilities that may split the designation of infection preventionist with the director of nursing, and they have more than 50 occupied beds. I would hesitate. I would approach with caution on that situation and make sure that if you are the director of nursing and you're also serving as the IP and you have no one else in your building taking on any responsibilities as the infection preventionist, we are seeing facilities cited, and I can give examples if you reach out to me privately of 2567s of facilities that received that citation. Because as the director of nursing in a facility with a certain bed size, you are required to have a full-time director of nursing, and full-time is defined as 40 hours minimum a week. And if you are supposed to have a full-time DON, you could not possibly do the infection prevention role on top of it, is the statement in the deficiencies. I'm not giving you an opinion on that. I'm just stating to you what the deficiency is and what the risk is for that. So I really encourage your facility to talk about that. If this is an area that you're not able to hire an infection preventionist, or due to size or bed size, and you're delineating out tasks across a couple nurses, I would make sure that you have that in writing so that you could demonstrate that upon request of how you're delineating, and that everybody that has some infection control tasks has received that specific education, that CDC, APIC education, or other recognized education on infection control. Are there any questions anybody has about that in the chat or else?
I'm not seeing anything in the chat, but you can feel free to unmute your line and ask a question live if you would like.
I forgot to say that. Yes, you can interrupt at any point in time if you have a question. We welcome the interaction. So, all right. So here is, from our perspective, from a nursing home administrator, validation of infection prevention, an IPC. So you're working. So worked at least part-time. What does part-time mean? Designated IP hours per week can vary based on the facility and resident population. And the amount of time required to fulfill the role must at least be part-time. So it could be 20 hours a week. It could be 10 hours a week. It could be 32. And Jenna is asking in the chat, how often must you complete training for IP? Yes, it is currently one and done, Jenna. However, I would encourage anybody that has taken that course over 2 years ago to go back, especially if you took it through the CDC train course. I would go back and review those modules. It's good just to go back and do that refresher. I would also encourage you to look for other opportunities for education at the next level. There are courses out there now to do increased, what is expect, I don't know, Patty took the course, Jessica, and I'm trying to remember what it's called, but it's a certification.
The certification.
There's a certification in infection control, and there's a lot of those opportunities. And I think Michigan and one other state in the three, and I don't know if it was Minnesota or Wisconsin, had a contract where they were offering APIC memberships and education for IPs and nursing homes to get some additional training. So again, watch your associations, if you are a member of the healthcare association in your state, or the nonprofit like Leading Age in your state, or the county medical care facilities, start looking for those opportunities to see if there's grant monies or other reimbursements for additional training. If you've taken the course and you've been doing this for a while and you're like, I'm ready to do the next step. There are opportunities out there. So the amount of time required to fulfill the role, and again, I would look at this based on your facility assessment. So if you're a facility, let's say you're a facility that's 45 beds. We just talked about how, okay, well, maybe the DON can take on that IP role. Okay. But what if your facility assessment for those 45 beds indicates that you're a full ventilator facility with 45 occupied beds? Minnesota is offering APIC membership. Thank you. I know Michigan just did, so did Minnesota. So back to my example. So 45 beds and it's a whole all ventilator facility. Do you think you could do that infection control along with being the director of a nursing on a 45 bed skilled vent unit? And the answer is probably not. I would say that your facility assessment probably would state that you're a high level care facility and that you would need more than a shared role with your director of nursing. You probably need a designated IP, to do some of those, to do that work because of the high risk of respiratory illness and other things that go along with having ventilator care in your facility. So use your facility assessment to really look at the core group of residents and where you're pulling your residents from and what your population needs are. And based on that assessment, you can determine if the individual functioning as the IP should be dedicated solely and how many hours should they be dedicated solely to infection prevention. So what is the data that you would look at? Historic infection data, community data, like where are you pulling residents from and how are they getting into your building? Are you doing a lot of short-term rehab or do you have a lot of long-term care residents in your facility? Are you pulling from a higher risk population? We have facilities that have C-ORIS. We have a facility here in Michigan that is a C-ORIS building, meaning that they take high, residents that are patients that have C-ORIS positive. They probably have one or two, infection preventionists working full-time in that building because that's a high-risk population. So looking at your facility assessment and, making sure that you're matching the needs of your residents to what you're providing from a staffing perspective. And then the second part of this is the person must be at the facility. They cannot be remote. This is not something that you can do by watching and looking at MDS data or PCC or Matrix from afar. You have to be in person in the building to physically look at what's going on in that building, observe the staff, observe the residents, making sure that the infection prevention practices of the building are being done to your policies, right? And it's really important that we put eyes on to do that surveillance. Surveillance, 75% of surveillance is physically looking at things and reviewing it, eyeballing it, in other words. All right, so here's some examples and some areas for IPC certification. We talked about APIC, that's the American, okay, help me with this, American something for infection control. APIC, I don't remember what the acronym is, but CDC. And then NADANA offers a certificate exam. And I know that the American Healthcare Association was at one time, I believe, offering a certification for infection control also. All right. So F882 does call out the role of the infection preventionist, and it talks about coordinating the infection prevention program for the facility. So you're like the captain of the ship for all things infection control. And your role generally is tracking resident illnesses, but you might also track staff illnesses. You probably prepare a lot of reports. You analyze results. You're looking at data. You're looking at root cause. You're making plans to correct issues. You're attending COPI. And then you're looking at that, making sure that appropriate measures are implemented. Now let's talk about enhanced barrier precautions, right? Somebody new is coming into the building, you're going to be making sure, thank you, Association for Professionals in Infection Control. Remember that. So you're looking at things to make sure that your measures are implemented to prevent the spread of infections and outbreaks. And you're looking at like enhanced barrier precautions, for example. Are your carts in the hallway? Are the carts stocked? Are staff using the PPE correctly? Are we doing N95 fit testing? Are all our new hires fit tested? Are we doing a vaccination review of residents and staff? When they come in, are we looking at the state registry to see if they've got their vaccines up to date? And then you're coordinating those vaccine clinics, possibly tracking it for residents and staff. And then we talk about coordinating surveillance and doing audits with other departments. As the captain of that infection control ship, you have a lot of people working on that ship with you. And so you're working with that team, with your director of nursing, your nursing home administrator, your MDS nurse, your staff development nurse. Hey, we need education on this. I'm seeing an uptick in this. Can we get some education and training for this? I observed this with this particular staff. Can we do some one-on-one coaching with them? Hey, MDS nurse, can you tell me what your infection data looks like for this month for UTIs? I want to see what you're tracking compared to what I have on my line listing. MDS nurse, hey, can you give me a report to make sure that we got, I resolved this pneumonia for somebody. Can we get it off of the MDS? Because we want to make sure our MDSs are submitted accurately with the correct diagnosis codes. So you're working with all of these individuals on your interdisciplinary team while you're coordinating that infection control program. And then as the IP, you're attending things like this to stay up to date on changes in guidance, learn about best practices, see how the regulations are being applied, and then help make recommendation and changes to policies and procedures. And then finally, the last part of this talks a little bit about antibiotic stewardship. And that's where we talk about meeting with those medical providers and reviewing lab results. You possibly review new admissions, antibiotic starts and stops, antibiotic timeouts. You really just need to be part of the team as far as knowing what's going on in the building and kind of getting a rhythm for what's coming in and what's going on and how you're responding to it. And it's tough because infection preventionists are usually a department of one. You usually report to the director of nursing, and you really don't have that authority that comes with a director role because the staff don't necessarily report to you. So as we go on, we're going to talk and we'll give you some tips and tricks about having those difficult conversations with staff and how to interact to get what you need from the staff that you're working with. On the bottom, there's a couple of really good resources here. The Wisconsin Department of Health put together this infection preventionist starter kit. I encourage you all to use that link if you are new to your role as an infection preventionist. There's some great resources in here to get you started. And then HQIN, the Long-Term Care Infection Preventionist Survival Guide, is another good resource for you to use from another QIO. Again, we share and share alike when it comes to resources. If we come across something that's already been created and we're like, wow, we want to share that, we're going to grab it and share it because that's part of our job to make sure that you have the best resources to do your job. All right. So let's talk about auditing and as part of F882, that surveillance piece of being an infection preventionist. So poll number 3, Jessica. Which of the following are examples of infection prevention surveillance? Overwhelmingly, it looks like everybody got this right, which is all of the above. Auditing can be anything, right, Jess? It can be whatever you feel it needs to be. So we're going to talk a little bit more about auditing and go. So what is auditing and observation? You will see the terms surveillance and auditing used intermittently. They really are essentially the same thing. Surveillance is how you're doing those observations and you're checking. It's the surveillance checking to make sure that your processes are being done correctly and that your policies make sense, right? That if your policy states to wash your hands before and after resident care, and the process is that I go and I foam my hands before I go into the room and I foam, after I performed care to that resident, that's the process. So your audit would be observing me foaming in, foaming out, whatever you decide you're going to be looking at in regards to that policy or procedure. So for auditing, you're going to want to select an audit or observation form, i.e. a tool. We call it a tool. Often those tools are online, they're paper, you can do them electronically. And the purpose is to confirm the person, first and foremost, you want to confirm the person that's conducting the audits is competent, like for example, in hand hygiene. So when we talk about hand hygiene, if I'm going to assign Jessica to go do an audit or an observation of her staff down in dining, Jessica, you're the dietary director today. So Jessica's my dietary director. And I'm going to say, hey, Jess, I need you to go do 5 audits for me on hand hygiene with your staff. But before I give Jessica those audits to do, I want to make sure that she's doing it correctly. And I want to make sure that if she has any questions about the process or when they're supposed to do it, that I've answered them and that she can verbalize to me competency in performing hand hygiene, right? That's just an example of that. So we observe for missed opportunities. So the surveillance can be, you can do it one of 2 ways. You can observe for correct or you can observe for missed opportunities. Most people observe for missed opportunities, i.e. improper technique. Let's say I go up to the hand sanitizer and I just tap it with my hand and I pretend that I'm hand sanitizing. True story. I'm like, well, I don't understand. Why would you do that? But yeah, it happened. I had to give feedback for that once. So that would be an improper technique, right? Or staff go in, and this is probably more frequent. Staff go in to use wash their hands with soap and water, and they don't do it for a long enough period of time. I can't tell you how many 2567s. You get those old school state surveyors, they will go and they will actually physically time your staff performing hand hygiene. So, make sure that your staff truly understand how long they're supposed to wash their hands. And I would do that with like a timer. I would put a timer like when you're doing training and education right by the sink and tell them this is exactly how long you have to wash their hands so they can physically feel how long they have to wash their hands. It's just an example. So we're observing for missed opportunities. And staff can either they need to be aware that auditing feedback is being conducted. And, you can do it with awareness or not with awareness, meaning you can do those kind of like secret shopper audits. But regardless of how you do it, when you give feedback, it needs to be non-punitive. So this is QAPI, right? Quality improvement is supposed to be non-punitive. It's not supposed to have a big stick, right? That you're not beating your staff up about not following a process. You need to be aware that you're providing them some type of coaching. That doesn't mean, okay, it doesn't mean that if this is the 10th time that I've talked to Jessica about not performing hand hygiene and I've observed her and I've had multiple coaching opportunities with her, that at some point that doesn't go into the next step, okay? But on the first go around, I'm probably not going to write Jessica up for not performing hand hygiene. So I'm probably going to do a verbal coaching, say, hey, Jess, can we talk? Hey, I just watched you go into Mary Sue's room and I didn't see you use hand sanitizer. And she's probably going, oh my gosh, yes, Mary Sue had her call light on. I was just focused. That happens. It happens to all of us. It's happened to me. We get focused. And it's like, oh my gosh, you're right. I didn't. I'm so sorry. But if Jessica goes, yeah, I know, I don't like to do it. Well, then that's a different conversation, right? So just be aware when you're providing a coaching, it can go one or 2 ways. And then that auditor needs to provide that feedback in a respectful, again, non-punitive manner. And it needs to be done for all staff, all departments, all shifts, and all days of the week. Midnight shift often gets left out of surveillance and auditing. And I will tell you, your most non-compliance is probably occurring between the hours of 5 o'clock at night and 5 o'clock in the morning, because you all, as infection preventionists, your supervisors, your directors of nursing, your administrators aren't in the building at those hours. It's sad, but true. And so having good leadership on those off shifts to help role model and help you with auditing and observations is key. We'll talk more about that as we go on in the next 5 weeks. So you're going to observe all staff and departments, and then you're going to do a month-end calculation of your compliance rate. And here's the formula for how to do a compliance rate. So it's the number of compliant people over the number of audits completed, and then analyze for patterns and trends. And then again, report it to QAPI. And I think this is where a lot of folks will stop, is they'll do the report to QAPI and they won't do the next step. So as the infection preventionist, if you're having a compliance rate that is less than what you would like your goal to be, so I always set a goal, right? We set a goal for hand hygiene. So for hand hygiene, everybody just spit in chat. It's been really quiet today, by the way. So tell me in chat what your percentage of hand hygiene compliance should be when you do an observation audit. Just as a rule of thumb, what do you like to have for your goal? And not everybody speak up at once because I know you're it's going to be a very quiet Thursday. So 100%. Wow, that's a good percentage. 80%. Okay. 90. Oh, good. Thank you. I appreciate it. If I give you virtual candy for participating. Thank you. So just consider yourselves having gotten, some type of piece of candy today. Greater than 90%. Yes. And, generally for like hand hygiene, you want to be somewhere between 90 and 95%. 100% would be awesome. But 80% might be really good for your building too if you're currently sitting at 55 or 60%, right? So I always say set your goals that are realistic and attainable. And if your facility is a facility that you go into as the IP, let's say you're the new IP, you come into the building and you do this like surveillance audit just to see what's going on in the building, and you get a 35% hand hygiene rate. Yes, we're going to talk about QAPI. That is my baby. And I will talk about that, Maria. We're going to get to that. I think that's week 5 or 6. So yeah, hold on. We will talk about QAPI. So 45% rate, right? First of all, don't have a panic attack. It happens. Don't freak out that you have a 45% hand hygiene rate. That just means you can go up, right? So you've got work to do, but you can achieve it. So if you're running a 45% hand hygiene compliance rate, setting your goal at 100% probably isn't realistic and not achievable in your first month. What I would recommend is that you post it, right? So the first step is, okay, you take it to QAPI and say, wow, we did audits and we're only at 45% compliance with hand hygiene. And I'm going to do additional education and training. I'm going to pull staff in. We're going to teach you how to hand hygiene. We're going to talk about soap and water. We're going to talk about ABHR. Maybe you need to add alcohol-based hand rub stations in your building. Common theme. We see it all the time. And then you're going to go back out and you're going to implement your change and you're going to audit again. And on the next audit, you're going to set your goal to be like what? Maybe 60%, 65% if you think you can achieve it. And you want to set your goals incrementally. So I think it's really important to know your facility and what their common behavior was in the past. Is there a trend? Or get that baseline. If there is no trend and you have no data, establish a baseline and you can only work up from there. Now, if your facility is at 90% hand hygiene and you're like, hey, I'm a ventilator building, I need to be at 100% hand hygiene compliance because it is an essential part of the care that the residents get, and we're a super high risk building. I probably would set my goal to be 100% observational hand hygiene. That would be a really good goal for our building. So enough about that, but it kind of talks about QAPI. All right. So this is from AHRQ. If you've never gone to their website, I encourage you. It's the Agency for Healthcare Research and Quality. Great stuff on their website. It's a competency check versus observational audit. It talks about the differences and the nuances between the two. Again, that link is live. So when you pull down this slide deck or you download it, you can go to all these links and use them. Pull the tools, read them, review them, and apply as needed. All right. Jessica, how are we doing for time?
We have a little more than 10 slides, I believe, and 7 minutes.
Okay, well, I think I'm going to stop here at standard precautions because I don't want to, this is going to go into enhanced barrier precautions. And historically, when we've gotten to enhanced barrier precautions, we've gone off the rails on conversation. So, which is okay. We expect that. It continues to be a hot topic. So are there any questions that anybody has? I know I got the question about QAPI. I will talk with you specifically. I'll talk about that. I believe in the slide at week 6, we talk about QAPI. Just want to, and if you have questions, drop them in the chat and we'll make sure we cover different topics around QAPI. I know QAPI is one area that we get a lot of questions about what should be included, how do I report off, and what do I do to respond to my data? So I'm going to stop sharing. Are there any questions or comments that anybody has that they would like us to cover on Appendix PP? I saw that Jess, you put in the chat, how to get facility to develop an IP committee. Ooh, that's a good topic. That's a good one. So you're not a committee of one, right? That's always pretty lonely when you're the only person doing infection prevention. So next week, we are taking a break. You might have seen in the weekly, and you're wondering why. So next week in the state of Michigan, we have something called the Governor's Award of Excellence. And so several of us will be attending that to give different care providers some awards here in Michigan for the state of Michigan. We're part of the data collection for that. So anything else in chat, Jess, that you're seeing?
No, I don't see, other than Margaret's question about developing the IP committee. Is that something you want to add into a later webinar?
No, I can talk about that right now. So we can talk about an IP committee. So depending on the size of your building, your infection prevention committee, generally the best time to have those discussions is at the beginning of your coffee meeting. And at your IP committee, you should include all people who have some role in doing infection control, such as dietary, housekeeping, maintenance, if they're doing your water management plan, your administrator, your director of nursing, and then possibly a nursing assistant or a nurse. And the reason for that is you're going to want to involve people with auditing. I've seen this done in a couple different environments where the IP would assign audits to a core group of people who've been trained to do the surveillance audits by them. So for example, like hand hygiene, cleaning of shared equipment, some of those basic surveillance audits that you're wanting to get data on. The other part of the IP committee that is really critical goes back to QAPI. They're part of your root cause. So let's say, for example, you have a urinary tract infection increase and you've noticed that your UTI rates month over month are increasing and it's like the third month in a row and they're not getting any better. And I would encourage you to pull that IP committee together and use your QAPI meeting and just say, hey, we're going to do an infection prevention root cause. Talk to your administrator about it and say, I want to do this. And they should be involved in that root cause so that everybody has a little different perspective that they come at, why something happens, right? And part of root cause analysis, whether you use the 5 whys or you use a fishbone diagram, which we'll talk about in week 5, week 6, how you get that root cause done with a multidisciplinary approach is often more thorough and involves more opportunities to identify the real cause of why you have urinary tract infections than just having 2 nurses in a room trying to canoodle, why do we think it's happening? For example, hand hygiene, cleaning equipment, right? Residents toileting themselves. Your housekeeping staff may tell their housekeeping supervisor, hey, so-and-so is taking herself to the bathroom and I don't think she can clean herself. Or your nurse's aides can say, I don't think she's doing a really good job with pericare. Or dietary might say, I'm getting all the fluids back on so-and-so's tray. They're really not drinking what they should be drinking. So getting different inputs from all the folks that usually would attend QAPI is probably your best opportunity to get that IP committee started. And then once you have that as part of your routine for QAPI, then you can possibly expand it to build upon it and grow it out. Jessica, any other seeds of wisdom on how to get that happening, make that happen in a building?
Yeah, I think you just need to get buy-in from leadership and make your team, and they're going to look to you to kind of spearhead the process. So just be prepared to lead that team.
Yeah. And start with something small. Don't chew the elephant all at once, right? Elephant's only eaten one bite at a time. That was the old adage. So start small. I would delineate it out from QAPI, but include it at the beginning, maybe of QAPI. And then, designate it as your infection prevention committee. When we get to QAPI, we'll talk a little bit more about what that looks like. So any other questions? Jessica dropped the evaluation in the chat. If you had other team members that you wanted to have attend but could not attend today, the recording will be available probably in 2 weeks and out on our website for review. And I think that's it. Do you have anything else? Anybody have any questions? Comments? I see a lot of familiar names. It's nice to see so many folks on the call today. So thank you all, and we will see you in 2 weeks. Have a great rest of your week. Take care.